Biohorizons 3.8 by 12 in site number 10. It's an anterior case where the other anteriors have been prepped. So now we've extracted and bone grafted site number 10. In a minute we will we'll get moving with that procedure. This is my first airing with the implant compare, so please bear with me. I may be not the most photogenic person. But glad to have been asked to participate in this. Glad to have a nice patient who doesn't mind us talking behind his back or over his face while we're doing it. And just as soon as the girls get set up, we'll kind of walk you through how we're going to use the XNav, do the calibration for that. We'll also show you that today we're using a B&Air Ichiro Pro handpiece, so it'll show you how we load in. It recognizes the Biohorizons implant from the code, and we'll kind of have all that recorded in data and chart for a patient. As they sit up, Shane, any questions?
X-Tag, right?
Yes.
Can you tell us about how long you've had your X-Tag and how often you use it?
I've had it since April of 2017. Dr. Rick Kimbrell and I were the first two, I think, that had it in Georgia. We saw it at my senior meeting that year, and we're really impressed with it. To this point, I think I've only placed one implant without it since that time. And that was at an off-site doing another implant program where we had to do it freehand.
Value-wise.
Okay, so if you look at, find out that anytime you do a guided surgery, be it a static guide with guides that are either placed on the teeth or bone guides or tissue guides, it's always going to be better than someone doing it freehand. In this case, this dynamic guide, as you'll see, we can move during our surgery if we wanted to move our guide a little bit mesial distal or a little deeper. We can always place our implant a little bit different. The whole thing that comes to mind with me, though, when somebody asks me why I use XNav, is just confidence. The confidence. I don't have as much space requirement. You'll see it's still kind of just like you're doing, in the mouth. There's no extra armamentarium other than just a. In this matter, which when we're doing it with a dentate patient, we can just have a clip. The girls have taken this beforehand. Little fiduciaries that are captured in the CT. In this case, we just CareSpring 8100. That's incorporated over to the XNav computer. From there, we can design the case. That same clip is put into their mouth, and there's going to be, in a minute, you'll see how it's got a little arm that comes out, and that's going to be the patient tracker. So let me kind of show what Dale's doing now. Our roving assistant is she's going to open up the Ichiro handpiece, and she's going to scan in the Biohorizons implant. So on that box, it'll show the reference number, the size of the implant, the manufacture date, all that's included. Then it's also set up in a way that as you start through the process, it'll have your different speeds that you would like that the manufacturer maybe recommend for each drill sequence, either the osteotomy drills or the bone taps if needed. In this case, I'll usually always kind of lower it down to maybe 450 RPMs. It's just my preference, not too fast. And ultimately, I'll use this. I'll crank it down to like a 50 RPMs with 35 newtons, and finally guide the implant probably 3/4 of the way into place.
Very good. And so it has cameras built into your light up there, correct?
Yes. So the cameras will when you'll see they'll kind of turn blue. The cameras will track the patients by the patient tracker, and you also like to see a little ball around my handpiece. Looks like hieroglyphics. That's kind of how it sees where the handpiece is. You always got to keep it a certain distance between maybe 70, 80 centimeters from the camera source to the handpiece. So I'm going to let Dale. We've got the implant placed, picked out on the handpiece motor B&Air unit. Now this is what would usually happen with me not in the room. She's going to go ahead and do the calibration for the XNav. I'm going to go ahead and lean the patient back and get him a little numb. Dale, you can give a little bit of Now she's going to calibrate the handpiece again. And this one, it has the disc, so it's going to run at like 15 RPMs, and it has to read the hieroglyphics, is what I call them, on the disc as well.
Oh, okay. I see. So you've connected this to the implant motor itself.
Right. And so this time it's going to see where the handpiece disc, the tracker disc is.
And so you'll actually calibrate each drill with this as well?
Yeah, each time you go to a new drill, you'll touch the drill to the. You'll see me touch it to a gold plate, is what it's called,
Okay.
and then that measures and confirms the length. So, like if maybe we'll start with the pilot drill, and then we might want to use a Biohorizons. In this case, I think they may all be Biohorizons. I may do a couple Versa drills, so some of those maybe have different lengths. So each time you touch it, that's going to take care of the length issue, and then you're always going to go back and touch it toward a tooth in the mouth. It's going to let you kind of calibrate and make sure that everything's ready for you to go.
So that'll work with any system then at that point?
Yes, any type of drill, any osteotomy drill. Yep. And there's certain drills, implant motor heads that will work. At this time, it's a Salvin and a W&H that they have to have the 20-to-1 on the motor.
And they have basically every system in their catalog too. XNAP does.
At this stage, it will be one of these days. At this stage, it's more of a generic where I put in this case. In this case, I added 3.8 by 12 by 2.9, and I can put it in there, and I can save it to a favorite.
Okay, gotcha.
They tell me that's coming down the line. All this sometimes is FDA, I guess, approval and all that kind of stuff. So they got to get the most bang for their IT work at the beginning, I guess.
And you use Biohorizons drills and occasionally use the denser burrs by Versa. What is your determining factor there when you decide to use a bone condensing burr versus just the system drills themselves?
Just if I need to maybe condense some bone, or in the maxillary, sometimes with the Versa burrs you can use those, and obviously they run in reverse and they kind of condense the bone and can kind of spread it out, so you can do a little osteodensification and also a little bone expansion at the same time.
Have you ever done a sinus bump with those? I've heard you can do those as well.
Yes, yes.
How does that work?
You just you go up to your sinus floor, stay just a little bit shy with your first couple of burrs. You get maybe about 3 burrs from the end, and then you kind of just start lifting it slowly. Each burr, you'll when you come out and change the size, you'll then add some Nova bone and lift again. So you'll have a nice little dome over your implant.
Steve Lennon just asked, what are the benefits of using XNAP over regular guided surgery?
Yeah, so you addressed it initially about why you like the system over doing like guided surgery, printing a guide. Can I go into detail on that again?
Yeah, I just like it because with guides, you've got it's a static guide, so it's a whole lot better than freehand. But with the static guide, it's either teeth bound, and it's pretty much whatever is designed. That's what you have. It also comes in, and you have a little more constraints in the mouth, especially in the posterior. On this, even though it's still a guide, it's a dynamic guide. So if we want to change anything, change our angulation or anything as we go through the process, it's easy to do. You're still guiding. You can bump your implant a little bit lower. You can move it, tweak it just a little bit if you needed to, and that's kind of why I like it.
From what I've seen, especially with a lot of our live surgeries, the biggest problem with guides, a surgical guide, is like you said, space often, and then you have to use their keys a lot of the times, their systems, and then half the time it doesn't seem like they see.
And that's the problem. If they seat wrong, I mean, if they seat a little bit wrong, then you're guiding it, but you're off kilter. And so again, this is for me. It's been confidence. It's been pretty much in the 2 years I've used it. When I place that implant, if I make sure I stay on the bullseye, as you'll see later, it'll be right where I planned it. And then there's a little less cost involved. For this, it cost me $99 of surgery to get that prepared. So most guides, when I use those, were $300 and $400. So it's a little bit of cost savings as well. This also gives you the option. It's not this case today, but if by chance you had a patient come in and it was an extracting tooth and they were ready to go that day and it was a good case and you had the time, you could pretty much treatment plan that if it met all your parameters and guide that surgery that day.
So
you were never going to do that with a guy that you had to have made. Okay. The other thing is, again, just bear with us. We'll have to do a little bit of. Can you pull that up just a little bit? Get me a little more. I just need the cord. This is down. Yeah. There you go. Perfect. Um, the biggest thing is, you'll see, we'll have to move this around, the camera around, and then we'll move the monitor around to where I can see that. So there may be a little bit of adjustment as we go in here. So just bear with us, and we'll let the film crew take care of that as well. So let me check one more time with anesthesia. Open. Going back to your guide question again, another great, on a tooth-borne guide, obviously you would not have to reflect, but like on like a full arch or some cases where you have to reflect to attach that to the bone, you got to reflect off a lot of periosteum. In this case, you're going to see me. I'm just going to take a little reflection at the top of the crest, and that's it. So we won't be damaging any periosteum. Therefore, we're not going to bother the blood flow.
Biohorizons implants.
Uh-huh.
Why do you find yourself favoring that system? And what has been your clinical success with it?
Hang on to that question just a minute. I'm going to let her kind of. So what we have to do here is we got to make sure that we get, if you can see on that. Let me ask one thing. Are you showing that, are you showing the, can they see this? Okay, can we get like his name covered over?
Yeah.
Okay.
Yeah, that's what I said. We're not yet. So.
I'm gonna need that moved this way.
Yeah, I didn't want to. I'll
I got
touch it after a while. Come right here. Come right this way, please. Will you just move this whole cord just a little bit for me? Just a little. All right, that's good. Now pull just the monitor one more. Pull it straight forward and then not forward anymore.
Would that be okay? So we can show
Oh, so you can.
Mm-hmm.
Yes, I gotcha. Okay.
Blade? Blade.
Yes.
Put this over there. It's sticky. Flip it around. There you go. Perfect.
All right. Now get whatever you need here. I'll try and.
Okay, so now what we have to do is make sure if you're looking at the screen of the XNAV monitor, you have to have both the patient tracker, which is connected to the X clip that you took the CBCT with. So that's going to track wherever his head is moving, okay? And then you've got my tracker on my handpiece. These have to be able to be seen by both of those cameras. In both screens, and they need to be anywhere from 60 to 80 centimeters away. And we're good. What they're doing now is just adjusting their cameras.
Good.
Okay?
All right, good deal.
So you can go, yeah, you can go down. Yeah, go down. Yeah, yeah.
Get my regular gown on.
Okay, how's this view, guys? You all right?
Yes, sir. Thank you. If it looks a little blue to everybody, it's because of the lighting we use with the system.
So we're going to do a little incision here more toward the palate than mid-crestal so we can save some of this keratinized tissue and move it on over. Using number 12.
We often like to cover the basics, so can
Okay.
I ask you what scalpel blade you use?
This is number 12. It's really,
12?
really fine point. And we're going to come back and we're going to use this sharp molt curette. Taught by Dr. Ed Mills in his maxi course and advanced course all these years, that we never want to do a tissue punch. We're just wasting good keratinized tissue. So we want to always reflect this tissue to the buccal. And that's about the extent that I'm going to have to reflect. We got nice, no granulation there on our crest. Okay. Okay. Now you see these screens, it's going to show us like our bullseye. It's where we want to be. It'll show us, in this case, we're aiming for a screw retained central, because I got plenty, like I said a moment ago, we love the buccal bone there. It's going to be lingual, a little lingually placed, so we can do a screw retained central, keep us away from worrying about any extra extraneous cement. As we work through this, it would not matter if we were using a 15 millimeter implant or an 8 millimeter implant. You'll see the bullseye and you'll see the graphic that shows the depth. It's only going to start counting once. So you see this is a little countersunk, so it'll only start showing me depth on the depth guide when I get to the top of the implant, and it's always going to stop at number 9. So at 9 o'clock. So like I said, if it was a 15 millimeter implant or if it was a 9 millimeter implant, it's going to be at 9 o'clock when we finish. So the first thing you're going to do is measure your drill length. Now we do a system check. And so we'll find this molar and we'll look. And in this case we see it's a little bit off, so we'll come back and kind of check our X-clip. And that looks nice. So see, sometimes the patient's lip or something may be moving that. Molt. You'll hear my staff jump in. I'll ask them questions a lot because they're here watching it all the time. The first thing I'm doing right here is I'm just looking to put my spade point right on the bullseye and kind of pierce the cortical plate. And I'll let the cameraman move, and then right there we're dead on, okay? So we're just going to start it, and sometimes this, like I said, this is the hardest part. It'll start, and we're through. Water. Got it open. Okay. Get me up to 50 RPMs here. Okay, now we're going to go down to 2.0. Already did that. Yep. Again, on each drill, we're going to check the drill length with the go. Then we come back to a molar. Push down again. Perfect.
Yep. What's cool, Dr. Pauley, you probably mentioned this already. I'm sitting here watching you, and I can see the exact depth of the drill, the angulation, everything on screen.
Perfect.
So right now it's saying you're 3.2 millimeters deep.
And you'll notice I won't talk too much during this.
So you have a base plate that you touch the implant drill to every time time you change to a new
Yes.
Yes, it like it kind of just recalibrates it.
verifies the size.
Yes.
Okay.
And
And it's not beeping at you like crazy and being annoying, so that's really
it
nice.
doesn't. Laurel, you doing all right?
Let me know, Tracy, if I'm binding on a tooth here in a minute. Okay, in this case, I've gotten down to like a almost 9. It binds on the adjacent tooth, so I'll just go to the 2.0 in the longer. Uh-huh. Yep. Again, we touched the gold plate. Now it's still going to know, even though I'm using a longer burr, it's got all that taken into account. Going back, checking at the tooth. There we go.
I assume you can use with immediates, grafted sides, no issue
Yep.
with anything, right?
Yeah. And if you don't mind, you guys can talk and the girls can talk. I won't probably answer you till I get out of this drill, okay?
No worries.
The longer the drill, the yeah. Just gotta line it up here. See, it's gonna turn green, and you'll get your beat. Let's go to Versa.
So
So
confirmation was that you
when it gets when you're green, it's about a so
Yeah, and I was asking you want 2, 3?
yeah 2 3 2 3.
So now
This is pretty. This is pretty. As expected, not dense bone in there. So I'm just going to slip over to my Versa burrs, and I'll run these in reverse. That'll just condense what bone we have there. Going back to your bullseye, when you get to green, you're about a millimeter from the. Yeah, that's fine in reverse. Got me in reverse. Now this reverse with Versa will give you a beep. Good. Make sure again I'm not touching it too.
So we're at 8.5, 9 millimeters. 10.2.
There's your green for getting close. There's your ding for being at depth. Give me the parallel pin. Parallel pin. Do a piece of floss on that. I'll do that after. Okay, so give me the next one. All right. Measuring drill length. Double checking on the tooth. Perfect. Next up. Yep. Next up, we're going to do the 3-0 Versa burr. This will probably be our last one.
Yeah, so 3-2 is kind of. Lorel, you doing okay?
Seems like all these birds, right when you get started at the cortical plate, they'll have a little bit of variation in size, so you have to kind of retweak your entry.
Chatter from.
Yeah. Sometimes with the Versa, you'll do a little pumping action.
Almost there.
Perfect. Next is a
3-3 is a 3-3.
next up is 3-3.
And like on here, you kind of stop at the 3-2.
And you got me the 3-0 gauge, 3-2. Here's our Biohorizons guide pin. Always want to have floss. We don't want to have to get through this and then have to worry about a foreign object being aspirated. So we got that. Let's see if I can move this out of the way just a little bit to kind of show our angulation, but we're liking that.
That looks great.
Perfect. Any questions? Okay.
Why do you choose Biohorizons? Like, which tapered system?
Yeah, this is Biohorizons tapered. It's got the laser lock as well, which I love.
And why do you like the laser lock?
It just really enhances, I think, crestal right at the on the implant, the crestal bone, and also on the healing abutments, and then on the final abutment, that little rough edge kind of promotes tissue attachment. Okay. Yeah, I think I will with this.
Look, Pauley, do you do educational courses yourself? Do you teach courses?
Yes, occasionally Dr. Rick Kimbrell is my friend from Vidalia, I'm sorry. We met through Dr. Mills's Maxi course, and then we did the advanced course for a few years. So we've been teaching courses for Biohorizons. We've done a couple for Bicon, and it's just kind of teaching a limited participation. Hold on just a minute.
Implant? Oh, you can't have that. Thought maybe you could reach it. No.
All right, now finish it out.
Almost there.
So it's called Buffalo Tactics. It's our little teaching educational arm. It's usually so the implant driver. It's usually a small limited participation group where we'll have one day lecture. Here in Atlanta, we've been lucky enough to be associated with Carestream, so we've had their facilities for our lecture didactic day, and then we'll come to my office with 12 to 15 folks, and we'll do a limited surgery, a couple live surgeries, a couple implant placement, and then seats on the second day. Rick, Dr. Kimbrell, a lot of times we'll do the course also at a little more resort friendly town that he has an office called St. Simon's. So I'm sure a lot of y'all have heard about that, but it's a small island on the coast of Georgia. And there we've got a great relationship. He's a pilot, flies some as well. So we've got an airport hangar there where we'll have our lectures, didactic, and then we go to his course on the second day and do the same sort of thing with live surgery, placements, impressions, and seats. I have really over the last couple of years gotten into the digital workflow. Let me have a little PRF liquid. I'm sorry. Turn me down to no water, 35 newtons, and 50 RPMs. This case, if you notice, and I need to be in forward. Sorry. Yeah. In this case, you notice that in the gray there, that is an imported files from the. These are imported intraoral scan STLs. So that way, the actual upper arch. I'll let you guys finish. Because I wanted 35 and 50. Okay.
Yeah, right there. You hit the speedometer.
Yeah, and that one I did earlier. I could do that one.
Yeah.
Couldn't do the.
Have it done.
Okay. So you import your as the workflow goes along, and maybe I'll show you this if you guys want, like a few minutes afterwards. But the workflow would be to import the scans. Look at your panoramic, draw your panoramic, then place the nerve, draw your nerves in, put a virtual crown, and then place your implant. In a moment, I'm going to tell you how I use that digital workflow. I'm going to finish and seat this implant. I'm going to drop a little PRF liquid here on it. And you can see how this Biohorizons just wicks that up. Perfect. Going to go to the go plate. We're just almost going to touch it. We're not really going to touch it, but we're going to go almost there to get our depth.
So with the implant, you don't quite touch the pad.
Right. You just get it close to where we can, where it sees it. I got to get back here to where I'm.
And Dr. Pauley, is that a regular or is that a platform switch?
See if we move. Maybe I'm out of it here.
Platform switch. Why do you like the platform switch?
Give me just a minute to place this, and I'll let you know, Shane. I like the platform switch as well as a little pearl that I caught from the ICOI recent meeting. You'll notice a lot of people are leaving these implants, like we've got this one planned, at 1.5 millimeters or so subcrestal. So that's going to take away that crestal forces. So, you know, if you stay up on literature, and you know, all of us who are really heavy into the implant arena seem to be doing that a lot. You find out that when we first started, you know, you would think that you could lose threads up to your first screw, and that would be acceptable. Let's see. I can't guide it all the way. So you see here, I'm able to guide this down 10.5 millimeters before my handpiece is going to bottom out on a tooth. Okay. There comes back out the handpiece with the Biohorizons 3.0 platform driver. Now I'm just going to do the final seat of 1.5 millimeters. In this case, in the anterior, I'm just going to use this straight driver. I feel like it gives me more control, more angulation. So, like when they were talking on the podium, when you don't have that pressure at your cortical crestal plate, you have less bone dieback, and you're even starting to see some cases where they'll have some bone grow back over that switch. So it gives a chance for, you know, the neck of your implant. The platform is narrower.
Biohorizons does not apologize for bone growth over the top.
Yeah, and like Justin Moody said that at the meeting. He goes, "How many of y'all ever had any problems with okay, let's take a minute. Give me just a break. No, you can take that off. Give him a break. Yeah. Oh, yeah. Sorry. Let's get one PA. Oh, that's good. You guys got it? Okay. All right. So in this case, even though we've got nice, keratinized tissue, I can always use more. So I'm going to take one of the PRF fibrin layers. Molt reflection, perfect.
And so, Dr. Pauley, is that a laser lock healing abutment? Or, what's the advantage of a laser lock healing abutment?
Again, this is going to give us a little surface on there that's going to really let the tissue want to attach to. And so when you take this off later on, you'll see that there's petite guy. Give me a little chromic. That's all we will need to close.
A lot of people might miss that. So you place your abutment through the PR.
Through the PR. And so that way, it kind of like the healing head's going to hold that in place. Even though I'm still going to stitch here, but I'm just going to stitch lightly because I'm not really chromic. Yeah. Oh, sorry. I'm not really. In this case, there's not a huge flap reflection. And again, we don't mind if the lingual kind of fills in by tertiary intention. So That'll just bulk it up even more. So I'm gonna put one more little piece of fiber in here too, Dale. Because again, you love the issue that if you could have bone grow over your implant, that would be perfect. And the other thing, you're never going to have any problem in the front if you can have 2 or 3 millimeters of soft tissue over your bone. In this case, you saw we got plenty of bone on the buckle. You know, we're always going to aim for 1.5 to 2 millimeters, hopefully 2, buckle bone and lingual bone. But if you've got tissue over that, that's even going to help us and give us another little safety barrier. All right, one more little piece of wipe that. Okay, anything else now you can ask questions on, because I'm kind of got it placed and not so tense, I guess, is when I'm using the motor. So anything you guys have or anything that people may be asking online, just let me know. Reflect there just a little bit.
So, with your implant placement, what's on your tray outside of your implant kit and your parts needed for the X guide? Is there anything unique on your tray? I know there's one thing specifically with the VersaBurst. Do you use that for every implant surgery? Is it just in case?
It's just in case. It's there. You know, it seems like anytime I'm in the anterior region, I'm definitely going to need it. And I do like those. I mean, they're really. I think when you're going in reverse, it gives you some control. I also have, like I said, the sharp molt. Otherwise, these days with Versas, sometimes in posterior, I would use periotomes for sinus lifts. Now, if it's just a little tiny bump, I'll be more along the lines to use the VersaBur for that. Otherwise, I mean, there might be some things that are unique. It's just the fact that when I keep going back to the Maxi course and Dr. Mills, but there's about 35 or 40 of us that took his advanced course, and we talk all the time. So when you're used to hanging around with a group like that, it seems like everything you do is just normal. But it's normal because you're with the group that you're with. So I found that to be really helpful in my years in the implant arena since I took that course in 2009. You know, you don't want to practice in an island. You want to get as much information as you can from CE, but then also you want to develop as many relationships as you can with friends and fellow practitioners, you know, where you can send out these cases pre-op, maybe in your planning, to discuss amongst yourselves.
Is Dr. Mills still teaching your course?
Yes, he still has his advanced course that meets once a quarter here in Atlanta. The Maxi course now is taught over at the Medical College of Georgia, or Dental College of Georgia, I'm sorry, new name, but Dental College of Georgia at Augusta. It's always that college associated with the AAID that would put that on. It was just for years it was based here in Atlanta. When it was here in Atlanta, it was kind of cool because, you know, I was lucky. The year that I took it, we did still have the first session over in Augusta with the anatomy department for head and neck, but then the rest of the time was here in Atlanta. So that was pretty cool because I didn't have to worry about traveling. I didn't have to book a hotel room.
So what suture are you using here?
This is just chromic. You know, I really don't need a whole lot of pressure. I don't need any kind of horizontal mattress or anything like that to hold this up. I'm just kind of reapproximating this and kind of bulking it up to hold my hold my PRF in place. Let's cut these a little shorter. Perfect.
Well, anybody watching that wants to maybe attend one of your seminars or courses, is there a way that they can find out more information about those programs you're offering or teaching?
Sure, they can look at Buffalo Tactics just like the old Buffalo Tactics.com. And we'd be glad to have them. Shane's usually working with me on a couple cases. You know, FYI, anybody here on the south side of Atlanta, on the 23rd, Dr. Paul Anderson has invited me to talk about my digital workflow at their study club on Tuesday night. And same sort of thing in
Still doing okay?
in Lexington, Kentucky on November the 3rd. So if any of you guys are up there, there's a study club by Dr. Vance and then with Dr. David O'Donnell. They invited me up, so they wanted me to come up and speak and then watch Kentucky beat Georgia. So
All right.
there you go. I guess it was 2017 when Rick and I went to our first Meisinger High Altitude Comprehensive Implant Symposium. I guess before then it was also called a Meisinger Bone Camp. So this is the 9th year that they've had it. It's a really good 3 days of information, podium speakers, 2 hours in the morning, 2.5 hours in the evening maybe, workshops on Thursday and Friday, maybe a workshop on the preliminary on Wednesday. You know, it's just it's a really cool study club kind of meeting. You go out, they've got Alex Miller and Shelley O'Toole from Meisinger really run a great shop. It's at a wonderful location this year. The first time I went, it was at this hotel. Then they shut it down a couple years and renovated. So that should be fun. It's kind of a really study club is what I would call it, because all the speakers pretty much hang around and talk to you. Wednesday nights you get there, there's a welcome reception, so they've got really nice food, drinks, beverages right there in the exhibit hall, so you can hang out, talk with your friends, talk with the speakers that are there, and then mingle with you know, groups like Salvin, Biohorizons has been there for a long time, XNAV, W&H, to name a few. Just so happens that this year they've invited me to speak, so I have an hour on the podium on Saturday morning at 7:30 for anybody who can get up that early and come out and see me, and I'd love to have you there. Again, it's going to talk about my digital workflow, like I've seen a couple patients, maybe one simple, one complex, from the data gathering, CBCT, intraoral scan, importing to XNAV, treatment planning with like Brian Lemke and Bibidex for your lab. So, you know, you do your virtual smile emulations or virtual design where you kind of, you know, you always want to have a prosthetic-driven implant placement.
Yep.
Like even in this case, you know, prosthetic-driven, I'm wanting to do, and had lucky had the bone to do this in a way where we can have screw-retained implant. You can do all that, you know, when, at the beginning. You don't want to be trying to figure out how you're going to do it at the end.
Yeah.
Again, this technology helps me do that. With XNAV, just kind of stay on my plan.
Well, they can reach out to you on Facebook, email.
Yeah, I'm
what's
on
best?
Facebook, Robert Pauley. I've also got a Facebook account with just my office at Dr. Pauley. The email address, the best would be drpauley@live.com. You know, you're going back to teaching. Shane can tell you, and his cohort, Matt Goff, invited me down to Shreveport this year to speak. Matt's kind of in charge with the DSO arm of Biohorizons, so the group practices, and he's on the western half the United States, but believe it or not, it comes all the way over to Mississippi. So I got to speak to a group of his in Shreveport. And that day we just talked about atraumatic extraction and bone grafting. But I feel that when we do those sort of things, I try to keep up, send out literature, send out cases, so try to keep everybody still involved. So
Well, hopefully
that's
we'll have
a
you
little
on
bit about me.
again.
Love to.
I've
Thank
done
you
it
so
on
much.
surgery.
It was. I think it went. I hope it went well. I hope it went well. Maybe you can give me some feedback
made it
from
look
your
easy, so.
from the people that remoted in.
Yeah.
Because this is my first time I've done a couple of live surgeries for some courses, but it's always interesting. Always the setup and stuff makes everything seem a little bit longer, but you know it's
Hour and a
9:30
half
here,
total.
and we've even did all the setup and stuff on that. So I could have had you maybe start at 8:30 or a quarter to 9, where I would have had the patient in the room. But thanks for being so considerate. Thanks for coming, and keep me posted on feedback. And then, do you tell people that they get to see this if they're not here? Can I tell anybody that wants to look?
Footage will be available next week, so anybody wants that's watching live, we can have the footage up next week.
Appreciate it. Thank you
Thanks,
so
Dr.
much.
Pauley. Thanks for
Thank
having
you.
us.